This masterclass provides a high-yield board review spanning perioperative antimicrobials, renal physiology, diuretics, and intravenous dyes. We will move through 4 specific sections: microbiology and SICP protocols, antibiotic agents and allergies, renal physiology and diuretics, and finally, intravenous dyes. Every agent discussed today requires the anesthetist to anticipate specific interactions with anesthetic drugs, shifts in hemodynamics, and the potential potentiation of neuromuscular blockade. Antimicrobials and diuretics reconfigure the entire anesthetic management landscape the moment they enter the patient's bloodstream. Human cells possess only a cell membrane, whereas bacteria and fungi possess a rigid cell wall in addition to that membrane. We categorize bacteria based on how their cell walls retain specific stains, dividing them into gram-positive and gram-negative cocci and rods. Antivirals act by inhibiting viral replication, suppressing rather than eradicating the infection, and frequently require renal dose adjustments. To reduce surgical site infections, the Surgical Care Improvement Project, or SIP, uses bundled interventions like targeted prophylaxis and preoperative decolonization. SSI risk factors include patient-related issues like diabetes and hypothermia, as well as procedure-related factors such as the duration of the surgical scrub or the failure to obliterate dead space. While SIP adherence prevents infection, the choice of a specific agent introduces mandatory hepatic and renal metabolic considerations for the anesthesia provider. The first dose of surgical prophylaxis must be infused within 60 minutes prior to the incision. Vancomycin and fluoroquinolones require a longer window, with infusion starting 60 to 120 minutes before the start of the procedure. When using a tourniquet, you must ensure the entire antibiotic dose is fully infused before inflation. Redosing is required every 2 half-lives, every 4 hours for cefazolin, or following blood loss exceeding 1,500 milliliters. Aminoglycosides, polymyxins, and tetracyclines can potentiate neuromuscular blockade and prolong paralysis, whereas penicillins and cephalosporins do not. Antibiotics must reach peak tissue concentrations at the exact time of incision without prematurely extending the patient's neuromuscular blockade. Antibiotics are responsible for 15% of anesthesia-related anaphylaxis, with penicillins and cephalosporins implicated in 70% of those cases. While 10% of the U.S. population reports a penicillin allergy, over 90% of these patients lack a true allergy upon skin testing. True IgE-mediated reactions manifest as urticaria, bronchospasm, or anaphylaxis, while symptoms like nausea are classified as intolerances. Cross-reactivity between penicillin and cephalosporins is remarkably low, between 1 and 3%, because it depends largely on the presence of this R1 side chain. Cefazolin is uniquely safe for most penicillin-allergic patients because it lacks the R1 side chain, unlike cephalexin or cefaclor. Documented IgE reactions require alternatives, like vancomycin or clindamycin, but avoiding first-line cephalosporins due to vague intolerances limits the effectiveness of patient prophylaxis. Cephalosporins are classified into 5 generations. As the generations advance, activity against gram-positive cocci decreases, while gram-negative coverage increases. Cefazolin is dosed at 2 grams IV, or 3 grams for patients over 120 kilograms. It does not cross the blood-brain barrier. Vancomycin is the drug of choice for MRSA, but rapid administration triggers histamine release, causing hypotension and red man syndrome. Clindamycin serves as an alternative for penicillin allergies in GI surgeries, but carries a distinct risk of pseudomembranous colitis. AHA endocarditis prophylaxis is reserved for highest-risk patients, such as those with prosthetic valves, previous endocarditis, or unrepaired cyanotic heart disease. Selecting prophylaxis requires matching the generation spectrum to the surgical site while mitigating specific intraoperative side effects. Perioperative oliguria is defined as urine output less than 0.5 milliliters per kilogram per hour. You must treat oliguria as pre-renal hypoperfusion until proven otherwise, responding first with fluid boluses rather than diuretics. Filtrate moves from Bowman's capsule through the proximal tubule and the loop of Henle before reaching the collecting duct. Diuretics acting upstream of the collecting duct cause hypokalemia and metabolic alkalosis, while those acting in the collecting duct cause hyperkalemia and metabolic acidosis. Diuretic therapy manipulates ion transport to increase urine output, but it does so at the cost of systemic electrolyte stability and does not reverse chronic renal dysfunction. Carbonic anhydrase inhibitors act here in the proximal tubule, causing alkaline urine and metabolic acidosis. They are primarily used to decrease intraocular pressure or CSF production. Osmotic diuretics like mannitol increase tubular fluid osmolarity to decrease water reabsorption, though they can trigger pulmonary edema in patients with renal failure. Loop diuretics inhibit the sodium-potassium chloride cotransporter in the thick ascending limb, making them the most potent class for diuresis. These agents cause rapid hypokalemia, which can trigger arrhythmias and significantly potentiate non-depolarizing neuromuscular blockade. Thiazides inhibit the sodium chloride transporter in the early distal convoluted tubule and are first-line agents for essential hypertension. Potassium-sparing diuretics act late in the collecting duct, presenting a significant risk of hyperkalemia. Loop diuretics are the most potent fluid managers, but they present the greatest immediate threat to intraoperative hemodynamic stability and neuromuscular predictability. All intravenous dyes can interfere with pulse oximetry, causing transient false desaturations and hypersensitivity reactions. Endocyanine green is metabolized by the liver, but carries a black box warning against enteral feeds due to risks of refractory hypotension and death. Methylene blue is a guanylate cyclase inhibitor used for vasoplegia, but it also acts as a monoamine oxidase inhibitor, risking serotonin syndrome in patients taking SSRIs. Indigo carmine is excreted quickly by the kidneys and causes transient hypertension, distinguishing it from the mechanisms of methylene blue. Even diagnostic dyes can actively disrupt neurochemistry and monitoring equipment, masquerading as harmless visual aids while introducing severe anesthetic risks. Let's review the board-testable essentials. Which antibiotic classes potentiate neuromuscular blockade? Aminoglycosides, polymyxins, and tetracyclines. What is the cross-reactivity between penicillin and cephalosporins? 1 to 3%. And why is cefazolin safe? It lacks the R1 side chain. Contrast the prophylaxis timing. Standard antibiotics must be in within 60 minutes, while vancomycin requires 60 to 120 minutes. Which diuretic class acts on the ascending loop and potentiates NMBs? Loop diuretics. Which IV dye risks serotonin syndrome? Methylene blue. Mastering the intersections of pharmacology and physiology ensures precise, evidence-based anesthetic management by accounting for the physiological cascade triggered by every administered agent.